Good evening, ladies and gentlemen. Over the next 15 minutes, I'm going really to discuss another important aspect in cardiovascular disease prevention and a reappraisal of the available evidence. These are my disclosures, my disclaimer, and this is the outline of my presentation. So I'll start by quick introduction, reviewing the data in relation to cardiovascular disease, and then I'll review the existing cardiovascular outcome studies, totality of the evidence in relation to all emerging therapies, and then I'll specifically home on pioglitazone in terms of its efficacy, in terms of cardiovascular disease prevention, before I conclude the presentation. So from the epidemiological aspects, if we look at, this is the data from the risk factor collaboration group, we can see to the left that a man who's aged 40 with a newly diagnosed type 2 diabetes and without any cardiovascular disease at baseline, they will, the years of life lost will be approximately 6 to 7 years. Half of it is thanks to cardiovascular disease. And if we look to the right, women are not immune. They have, again, the same risk of cardiovascular disease. And we know very well, and we understood it now, that by the time women develop type 2 diabetes, they will lose the protection which is conferred by their gender. And therefore, it's very important that they are subjected to the same intensive preventive measures as their men, as men. And this is the data from the Swedish registry, and what it shows is really controlling 5 risk factors. These are blood pressure, lipids, HbA1c, albuminuria, and smoking. And we can see that as we control more risk factors, if you go from bottom to top, the more risk factors you control, the less is the risk of, in this setting, myocardial infarction. And if we control all the 5 risk factors, then really we render the risk similar to somebody without diabetes. So that's something which came from the Swedish registry, underscoring the importance of stringent control of all risk factors. What's worrying, however, is that although we are seeing decrease over the years when it comes to trends, decrease in mortality, cardiovascular disease, cardiovascular death, but the gap between people without diabetes in red and people with diabetes in blue remains wide. If anything, if we look to the far right, this will give us the impression that the gap is getting wider. Really raising the question about the level of intervention that we are offering our patients and the need for really more therapies which will reduce the cardiovascular risk. Now let's look at the totality of the evidence. And if you look at the data from DPP-4 inhibitors, we all know that they don't reduce cardiovascular risk. So we have the data from saxagliptin, allogliptin, sitagliptin, and linagliptin. Linagliptin was in the cardiovascular outcome trials was compared to a placebo and was compared to glamipiride. Both of these studies showed cardiovascular neutrality. And then if we move to SGLT2 inhibitors, we saw from the data from the MPREG reduction in the MACE, with the similar thing we saw with the in the Canvas program, but we didn't see it really with the in the Declare TIMI, largely reflecting the fact that the biggest proportion of patients in this study, 60% were primary prevention, and reduction in MACE was not evident in those population. And then if we look at the data from articulofloxacin, again, we saw that although it had a population similar to the MPREG, there was no reduction in the 3-point MACE, again raising the question as to whether SGLT2 inhibitors are not the same. But having said that, also reinforcing maybe the notion that their main effect is on heart failure and progression of kidney disease. And we know very well from the data that their effect in terms of modulation of atherosclerosis is at best minimal. And then if we look at the GLP receptor agonist therapy, again, pooled data indicate cardiovascular benefit. However, that does not apply to all the agents. So we saw positive studies with Sustained 6, with semaglutide, with liraglutide, as well as with dulaglutide. But what we also learned from the limited data is that when it came to secondary prevention, these therapies do reduce the 3-point MACE, but although the studies really were not powered to look at primary prevention, when you pool the data, you will find that they don't have benefit in terms of 3-point MACE reduction in subjects without cardiovascular disease at baseline. This data did not apply to liraglutide, where benefit was seen in a large cohort of a primary prevention population. So let's look at pioglitazone now in its efficacy data. We know that the two fundamental defects in type 2 are insulin resistance and beta cell dysfunction. And when it comes to insulin sensitizers, they exert their effect on the adipose tissues, on the muscle, and on the liver. At the level of the fat cells, they reduce lipolysis and enhance insulin-stimulated glucose transport. At the level of the muscle, they increase glucose uptake thanks to reduction in the lipolysis and the free fatty acids. And then at the level of the liver, they decrease gluconeogenesis, and because of that, they decrease the hepatic glucose hepatic glucose production. And if we look at and this is really a schema to look at the way the pioglitazone works. So primarily on PPAR gamma receptors at the adipose tissues. So they enhance the differentiation of the pre-adipocytes. They increase the free fatty acid intake, and because of that, they decrease the free fatty acids, and this results in improved glucose uptake at the level of the liver, and this results in glucose lowering. They also have a direct effect on the liver, and they decrease the gluconeogenesis, which translates again into a reduction in glucose level. And then at the level of the adipose tissues, they increase the free fatty acid uptake, lipogenesis, and the adipose tissue proliferation and the subcutaneous tissue, and they also increase the glucose uptake. Efficacy-wise, they are very efficacious, and the data are showing HbA1c reduction in the magnitude of 1% or greater in most of the studies. So they're one of really the most efficacious therapies when it comes to glucose reduction. When it comes to the lipid panel, obviously they improve the atherogenic lipoprotein phenotype, so they decrease triglyceride, increase HDL, and this probably one of the mechanisms by which they exert their benefit. They also reduce systolic and diastolic blood pressure, and this has been replicated in many studies. Now let's look at the cardiovascular outcome trials with pioglitazone. We'll start with the famous trial, the PROACTIVE study, included more than 5,000 patients in 19 European countries. Patients randomized to pioglitazone or control groups. The primary composite endpoint was beside the 3-point maze. It was also included some subjective endpoints which are no longer really included because they are so subjective. So amputation, revascularization were included, and this may have really skewed the data, as I'll show you in a few minutes. So patients with type 2 diabetes were included, in who have suboptimal glycemic control. Established cardiovascular disease, which is defined as one or more of the following: an event in the past, or an intervention including stent or CABG, ACS, or classic symptoms of peripheral vascular disease, or amputation related to peripheral vascular disease. As I pointed out, their endpoints, the primary endpoint, was not the classic that we see with the rest of the cardiovascular outcome trials. And I think people learned an important lesson at that time when they included subjective endpoints such as leg amputation. A surgeon may decide to amputate, another conservative surgeon may decide not to amputate. So that's really subjective. On contrast to a myocardial infarction is a myocardial infarction. So there are no two ways around it. So when it came to the primary endpoint of the composite of the 3-point MACE plus major amputation plus leg vascularization, there was 10% relative risk reduction, which did not achieve a statistical significance. But if we look really at the 3-point MACE, and this is really the outcome which is now examined in all cardiovascular outcome trials, GLP receptor agonists, SGLT2 inhibitors, and DPP4 inhibitors, we can see that pioglitazone resulted in, and I must say, obviously, this is a nominal p-value, but there was 16% relative risk reduction in the 3-point MACE with a p-value of 0.027. And this effect was maintained throughout the study. Patients with pioglitazone, they had a reduced hard endpoints compared to the control groups. Sub-analysis was done to look at the impact of treatment with pioglitazone in patients with pre-existing or previous myocardial infarction. And what we saw is that when we look at the fatal and non-fatal MI, there was significant risk reduction of 28% the subject who sustained a previous MI. And we look at the ACS, where there was 37% relative risk reduction with a nominal p-value of 0.035. Another sub-analysis was done looking at the strokes, and again, in people with previous stroke, and we saw a 47% relative risk reduction in subsequent stroke with a p-value of 0.008. So in patients with a previous MI, there was a reduction in subsequent MIs with a relative risk reduction of 28%. There was also 48% relative risk reduction in subsequent stroke in patients who had a previous stroke. Data which is indeed very impressive. A number of factors which were advanced that brought about the benefit, including really anti-inflammation, increase adiponectin, decrease in obviously intimate thickness, improvement in blood pressure, lipids, and albumin, urea, and reduction in the visceral fat. There was increase in heart failure, so there was an imbalance. However, when investigators looked at fatal heart failure, there was no imbalance and no difference in fatal heart failure. There was a suggestion that perhaps there may be an increase in bladder cancer, but when they excluded the events which were observed in the first year, there was no significant difference in bladder cancer, but the FDA mandated a 10-year observational data, and I'm going to share that with you shortly. Pioglitazone was also looked at in patients with insulin resistance, including patients with pre-diabetes in the IRIS, a more recent IRIS study in patients who sustained a previous ischemic stroke or TIA. And what the investigators demonstrated, a 24% relative risk reduction in fatal and non-fatal strokes and fatal and non-fatal MI in this group of insulin-resistant patients. Besides having significant reduction in the primary endpoint, it's worth noting that there was a significant reduction in the risk of diabetes in these pre-diabetic cohort. Bone fracture was noted, similar to the what has been seen previously, and the suggestion with this regard and the recommendations, obviously, patients at high risk, including women, mainly women who have osteoporosis, established osteoporosis, should avoid these agents, and one really should carry on with the screening in the usual manner recommended by the guidelines. With heart failure, this study excluded patients with heart failure at enrollment, and with that, there was no really increase in the risk of heart failure in the IRIS study. So the IRIS study really confirmed what we knew before from the data of the proactive study in terms of reduction in major cardiovascular events. Barry 2D study, again, although it was negative study, but when it came to revascularization in the whole cohort, there was a reduction, as you can see there, 20% versus 25% in the controls. And when you look at the CABG stratum, again, there was a reduction in revascularization in the group who received pioglitazone, again, consistent from the proactive study. And finally, this is the registry from the Kaiser Permanente. And again, that registry showed that there was no increase in the risk of bladder cancer. And this was very reassuring indeed. Positive effect on all parameters of NASH. Because of time, I'm not going to go into details of that, but pioglitazone improved really all the outcomes of NASH. So, ladies and gentlemen, to conclude the presentation, insulin resistance is linked both epidemiologically and pathophysiologically with cardiovascular disease. In the IRIS, pioglitazone reduced the risk of fatal and non-fatal MI in patients with insulin resistance. Pioglitazone is the only oral glucose-lowering agent to reduce atherosclerotic events. Pioglitazone is also the only drug to prevent diabetes and improve atherosclerotic cardiovascular disease in the same trial. Pioglitazone appears to have potent beneficial effect in NASH, including histological changes. There are, of course, some concerns with regard to weight gain, which is limited, but obviously it can be reduced by giving a smaller dose. The water retention, heart failure, so we should avoid in patients with heart failure, bone fracture. So again, clinical acumen dictate avoiding it in patients with established atherosclerosis. And when it came to bladder cancer, the proof really has been questioned. And therefore, based on this, the role of this drug needs really reappraisal and reassessment in the treatment of patients with type 2 diabetes, especially in those with cardiovascular disease. Thank you very much for your attention.